بسم الله الرحمن الرحيم. This is a series of lectures. We're going to discuss the different breast cancer classification methods. There's another lecture online which is entitled the same, but in this series of lectures, we're going to go into deep details within the subtypes and how they appear. And I'm going to discuss the different pathological entities of breast cancer from the perspectives also of the pathologists, of the oncologists, and the surgeons in order to be able to understand how they think to write an appropriate report. We should know what they request exactly in their report. Actually, breast cancer is a genetically and clinically heterogeneous and complex disease with different morphological appearance, histopathologic types, and molecular subtypes. And these differences lead to a difference in the imaging features of the different types, in the response pattern to various treatment methods, in the prognosis and clinical outcome of breast cancer. The ideal management of patients with breast cancer requires the collaboration of expertise of specialists from different specialties. The decision making in breast cancer management is no more taken on individual basis, but it is taken by breast cancer multidisciplinary teams, which are a team of key healthcare professionals who meet regularly to discuss individual patients and to contribute individually to taking clinical decisions. Actually, most breast radiologists look at breast cancer from a very narrow point of view until they start joining breast cancer multidisciplinary team. Those who do not, they usually have a symptomatic or an asymptomatic patient, and they end up by just saying that the patient has a benign or a malignant pathology, and maybe one or two of them will go after the pathology, get the pathology result, and know that the patient is what he said was right. It was the patient, did the patient, yes, had a benign or a malignant tumor. But actually, where we think that the story ends is actually where the story starts and not where the story ends. And we begin to learn wisely when we're willing to see the world from other people's perspectives. And this is what actually happens to us when starting to join breast cancer tumor boards. We understand how valuable we are. Radiologists actually play an integral role in breast cancer MDTs. We have to tell the surgeon the tumor size, the multiplicity, the relation of the tumor to the skin, the lymph node status, and usually the surgeon waits for us to say whether the patient is a good candidate for conservative surgery or no. And if the patient has received neoadjuvant chemotherapy, the surgeon needs to know from us the amount of residual disease. For the medical oncologist, we should tell them the tumor size. Is it an early or a locally advanced breast cancer? And is there metastasis to anywhere in the body? And the lymph node status? If the patient is receiving neoadjuvant chemotherapy, we are responsible for assessing the response to this neoadjuvant therapy. And if the patient is receiving irradiation, we have to say the effect of the irradiation on the chest. And even with the pathologist, we have to discuss with the pathologist how to biopsy the lesion and what was biopsied, and is the pathology and radiology concordant or no, or should we do a rebiopsy, or the initial biopsy was enough. All this is valuable information that everybody in the tumor board is awaiting for the radiologist to say. And actually contributing to a breast MDT allows the radiologist to endorse his value as a precious member of the healthcare team. And that's why to be able to join any multidisciplinary breast cancer team, you have to know breast cancer in depth, and that's what we're going to do in the upcoming series of lecture. Actually, breast cancer classification methods divide breast cancer into categories according to the different criteria that serve the different purposes. We're going to discuss the histopathological types of breast cancer, the grades, the stages of breast cancer, and the molecular subtypes. And as I said before, we are going to go in depth and not superficial like I have a lecture online which discusses this, but it doesn't go in deep depth in details of these subtypes of breast cancer. And whenever we're going to discuss any of this classification method, we have to answer the question, do they have specific imaging features? And is it enough to know this classification method or no? And we start by discussing the histopathological subtypes of breast cancer. Before doing so, we all have to know a term which is the terminal duct lobular unit. We all know that we have 15 to 20 ducts which open through the nipple. These ducts ramify until at the end they reach the terminal duct, and the terminal duct is the acini opens within the terminal duct in a way which is similar to the ramification of the trachea, the left and the main bronchus, and then the bronchi until we have the alveoli. And actually, it is important to know this unit within the breast because it is the site where most cancers arise from the breast. If the cancer arises from the ducts, then we have the ductal carcinoma in situ, and not strictly speaking if it arises from the acini, because we know more details when we go to the invasive lobular carcinoma, then we have the invasive lobular carcinoma. And if it arises from the stroma in between the ducts and the lobular carcinoma, then we have the breast sarcomas. So according to the lining epithelium, whether of the ducts or the lobules, for the duct, we have the ductal carcinoma in situ with its many subtypes. We have the infiltrative duct carcinoma, again with underlying subtypes. We have from the lobules, we have the lobular carcinoma in situ, which is no more considered a neoplastic process. It is a precancerous process, but not an actual malignant lesion. And the invasive lobular carcinoma with its subtypes. By far, the commonest of all these subtypes is the invasive duct carcinoma, not otherwise specified. And from the stroma, we have the breast sarcomas, the most famous of which is the Phyllodes tumor. We're going to learn together in the first lecture, we're going to discuss only the ductal carcinoma in situ, but we're going to also discuss the different specific imaging features of many of other different types of histopathological types of breast cancer. Before doing so, we have to look at a cross-section within the duct. We will find that the duct is delineated with the luminal epithelium. At the basement of the luminal epithelium, we have a myoepithelial layer, and this is very important for us today, this myoepithelial layer, and then we have the basement membrane. This is a normal duct. If the cells of the duct start to proliferate, but they look exactly like the mother cells, then we have the typical ductal hyperplasia, and this is an insignificant process. But if these cells that proliferate look different from the mother cells, then we have the atypical ductal hyperplasia, and this is very important to us because this is the precursor for development of a ductal carcinoma in situ. And as you see here, this is an actual malignant process with evident nuclei. And then if the ductal carcinoma proceeds, we have the invasive duct carcinoma, which penetrates the myoepithelial layer and the basement membrane to reach outside the duct and spread, and it might also spread to the rest of the body. Today, we're going to discuss only the ductal carcinoma in situ in details. The ductal carcinoma in situ or in situ, as in some places, some people like to call it in situ, it is characterized by proliferation of malignant epithelial cells lining the terminal duct lobular unit, without histological evidence of invasion through the myoepithelial layer or basement membrane. It is said that approximately 30 to 50% of all DCIS cases will progress to invasive breast cancer. And because it is important to make sure that this myoepithelial layer or basement membrane is intact, sometimes when sitting in a tumor board, that you will find the pathologist saying, this is a carcinoma in situ, and I did a myoepithelial marker in order to make sure that there is no invasion. If we look at the normal appearance of the myoepithelial layer, it is very difficult based on this image to say whether it is infiltrated or no. And therefore, the pathologist sometimes has to do what is known as a myoepithelial marker, where the myoepithelial layer is stained differently from the malignant cells. And now he can say that I have an intact myoepithelial layer and there is no invasion outside the myoepithelial layer or basement membrane. Ductal carcinoma in general is different because there is no sufficient lymphatic or sizable blood vessels present within the lining epithelial of the duct, so that no metastatic spread can occur until the malignant cells penetrate the basement membrane and it becomes an invasive cancer. Skip lesions are also very common with ductal carcinoma in situ. About 10 to 20% of ductal carcinoma in situ we have bilateral disease. From the surgeon's perspective, it is important to know that he is dealing with a carcinoma in situ because in these cases, axillary dissection is not justified. He can only do a sentinel lymph node biopsy. If he's going to do a mastectomy for the patient, he does a sentinel lymph node biopsy in order to test for the lymph nodes, because as we will know later, sometimes we remove a carcinoma in situ and after surgical removal, the surgical pathology comes back stating that this carcinoma in situ has an invasive component, and the management here changes from a carcinoma in situ to an invasive cancer. And this is very important. If the patient is doing a mastectomy, he should test for the lymph nodes. But if he's doing a conservative surgery, he doesn't open the axilla. If the pathology report comes back stating that there is an invasive component, then he will do a sentinel lymph node biopsy after that. We might think that because carcinoma in situ is an early cancer that we do more conservative surgery, and the answer is no. In many cases of carcinoma in situ, we have to do extensive surgery and mastectomies if we have a locally advanced lesion, if we have multicentric disease or diffuse disease within the breast. For the surgeon, there is also controversy regarding the optimal margin width for ductal carcinoma in situ, and this controversy has actually existed for decades. But in the place where I work, in Asr-Laini and in Bahia Hospital, we follow the guidelines stating that the margin threshold should be 2 millimeter for DCIS. And if we have a surgically excised DCIS with a close margin or a margin which is less than 2 millimeters, sometimes the surgeon resends the patient for us to perform an immediate post-operative MRI because he wants to know, he will do resurgery for the patient, and he wants to know whether he should do just a wider margin or the patient has to perform a mastectomy because there is other sites where the carcinoma in situ is present that we did not see preoperative. And that's why in many cases of carcinoma in situ, when we have a dense breast, it is preferable to perform a contrast study, whether contrast enhanced mammography or MRI, to identify or exclude the presence of multicentric disease before operation, especially that after in this lecture also we will know that not all ductal carcinomas in situ are easy to be seen on mammography or ultrasound. We characterize them usually by the presence of microcalcifications taking a specific distribution, but this is not always the case because we have non-calcified ductal carcinoma in situ, and sometimes they are missed as normal parenchyma. For the oncologist, the carcinoma in situ is different. We only have to test for the ER if positive, then the patient has to receive tamoxifen or any other aromatase inhibitors. And actually, for the oncologist also there is a difference. If the pathology comes stating that this is a ductal carcinoma in situ and with microinvasion, he just ignores the microinvasion and he considers this as the DCIS. And this DCIS follows the margin guideline and the treatment options given for DCIS. So it is not considered an invasive cancer if we have microinvasion. But sometimes the surgical pathology report comes stating that this is an invasive carcinoma with a DCIS. Even if it was diagnosed preoperatively as a DCIS, This will be ignored, and we will consider a patient an invasive cancer. And in these cases, we have to test for the ER, PR, and HER2 and see the proliferative index, and the patient receives management and treatment, and the surgical margin guidelines follows the invasive cancer and not the carcinoma in situ. So we have to take care. We have two types of pathology, three types: a pure DCIS, DCIS with microinvasion. It is still a CIS, but invasive cancer with a DCIS is considered as an invasive cancer and not a DCIS. The ductal carcinoma in situ, from the point of view of pathologists, are classified according to the nuclear grade and according to the architecture of the lesion. According to the nuclear grade, we have 4 points the pathologist has to comment on 4 points: the presence of glands or papillae, the nuclear grade, the mitotic grade, and the presence of central necrosis. Each of these 4 grades, just globally speaking, we're not going to go into details, but each of these grades, each of these factors is given a grade of 1 to 3. It is given a score of 1 to 3, 1, 2, or 3. And then we add the score for each tumor. If the tumor scores 4 to 7, then this is a grade 1 tumor. If it scores 8 to 9, this is a grade 2 tumor. If it scores 10 to 12, then this is a grade 2, 3 tumor. And of course, a grade 1 tumor is well differentiated with a good prognosis. A grade 3 tumor is poorly differentiated with a bad prognosis. According to the architecture, ductal carcinoma in situ is divided into the comedo type, and this comedo type is the worst type. It is usually high grade with the central areas of necrosis. The cribriform is, they say it is cookie cutter like the cookie with the chocolate on the cookie. It has fenestrations within, and it is often filled with calcified secretory materials. So we find calcifications very common with the cribriform type. The micropapillary and the papillary type, the tumor forms papillae, but in the papillary type, these micropapillae, they are devoid of vascular fibrovascular cores, while in the papillary type, there is a fibrovascular cores. And lastly, we have the solid type. And before discussing the imaging features of ductal carcinoma in situ, we're going to revise together how we comment on the calcifications in the breast, because we will find that most ductal carcinoma in situ will present with malignant calcification. And to comment on calcification, we should describe the morphology and the distribution of this calcification. The morphology was used to be classified into benign, intermediate, and suspicious, but they said there is nothing called the intermediate. Even if you have a low suspicious calcification, you should biopsy this calcification, and that's why now we classified into benign and suspicious. We have a long list of benign calcifications, and what is common with these benign calcifications is that they are all macro. We do not need to magnify in order to see the calcification. And we also have a long list of suspicious. These were the ones which were considered intermediate concern, but what combines all the suspicious calcification, with the exception of the coarse heterogeneous, is that they are all micro, and to see these micro calcifications, we have to magnify in order to see the calcification. For the distribution, the calcification might be diffuse, regional, grouped, linear, or segmental. And if we go from up to down, we are going from a benign to a malignant distribution, which means that the grouped, the linear, and the segmental are the most impressive of a malignant pathology. And the grouped, what we usually used to call the grouped as the clustered classification. We see examples. These are the dermal classifications, and we only know that they are dermal if we see them tangentially on the mammogram. These are the vascular calcifications. They look like worms within the breast. This is the popcorn, which characterizes the involuted fibroadenoma, and these are the rod-like calcifications which occur in the ductal wall. wall. These are the rounded calcification, the dystrophic or suture site calcifications, which occur at the sites of operative beds. This is the milk of calcium, and this is a type of fat necrosis, the oil cyst, which shows the rim or the eggshell calcification. And these are examples of the suspicious calcifications. The fine pleomorphic, they are fine, very small, with different sizes and shapes. And this is the fine linear branching calcification. This is the amorphous calcifications with different, no specific size or shape. And this is the coarse heterogeneous. And sometimes we might think that these coarse heterogeneous might proceed to the popcorn calcification, but at this stage, we can never be sure unless based on a biopsy. For the distribution, the microcalcification might be diffuse, regional, which is occupies a large region, not essentially directed towards the nipple. A segmental starts from the nipple and ramifies with the ramification of the ducts, and the grouped, which we used to call the clustered microcalcification. This is the linear distribution of malignant calcification, and this is the linear also calcification. Going back to the ductal carcinoma in situ, we said that the vast majority of mammography detected DCIS manifest as coarse, heterogeneous, or fine pleomorphic microcalcifications with a grouped or linear branching pattern. I always say whenever you have a calcification, microcalcification, taking a specific distribution, you should take it of concern. This is a case of DCIS with grouped calcification, and this is a linear branching, and we might also call it a segmental calcification. Less commonly, DCIS appears as non-calcified asymmetry, and this decreases the sensitivity and specificity of mammography. Like in this case, we have something here, we cannot call this as a mass, this is an asymmetry. It's seen in the CC view, and it is seen in the mediolateral oblique view, so this is a focal asymmetry. And in these cases, we cannot say we have a carcinoma in situ unless it is biopsied, and when we see a non-calcified DCIS, it is preferable that you do a contrast study, and in this case, we performed contrast mammography, and there was very faint calcification corresponding to this asymmetry. This was a faintly enhancing low-grade DCIS. Less commonly, DCIS might appear as a non-calcified mass, like in this case, we have a DCIS presenting as a non-calcified mass. Multiple lesions, as we said, can occur in the same breast and in the contralateral breast as well. We had this case with the pro-DCIS in the right breast outer quadrant. There was an asymmetry with microcalcification, a grouped microcalcification, typically malignant, but we have to take care and we have to avoid the satisfaction of search or the happy eye syndrome, because there was another group of microcalcifications in the inner breast quadrant. And of course, knowing this, the management of the patient will change totally from a conservative surgery into a mastectomy. DCIS, as we said, can occur with invasive cancer in the same lesion, in the same breast, but in a different site or in the other breast. In this case, we had a proved case of invasive duct carcinoma and carcinoma in situ. And as said, that we said that these cases are usually managed as invasive cancers and not as carcinoma in situ. But when we have a case which, like this case, although it is very evident, in a very dense breast, we have to proceed to another imaging modality to see the extent and to assess for the multiplicity of lesions. This is the case magnified. We have pleomorphic microcalcifications within a mass. This was a mixed invasive duct and DCIS. When we performed contrast mammography, there were two other lesions away from the index lesion, and this is very important information to give to the surgeon. This is another case also. She had a mixed, she had a ductal carcinoma in situ and an invasive cancers in two different positions in the breast. She had these evident segmentally arranged pleomorphic microcalcifications in the right lower outer quadrant. But when we did the contrast study, we will find that there are two patterns of enhancement. Following the DCIS, there is very subtle or faint enhancement, and this was a low-grade DCIS, while in the part where the invasive tumor was present, there was a massive clumped non-mass enhancement. On MRI, which is considered the modality of choice, and I add to the MRI the contrast mammography, pure DCIS usually present with any form of non-mass enhancement, but the commonest form is to find a segmental and clumped enhancement. In this case, we have a proved case with DCIS and microcalcifications within the left breast, and this is how it appeared on the MRI. These are the MEP images showing segmental clump mass, non-mass enhancement. Again, here we have a segmental enhancement on the diffusion, on the subtraction and the dynamic images. But in the diffusion image, it depends on the cellularity of the carcinoma in situ. If there is no no breaking down, like what happens in the high-grade DCIS, then the tumor, like this tumor, might show restricted diffusion. But if we have breaking down, there might be facilitated diffusion. As we see here, there is clump, segmental non-mass enhancement, and restricted diffusion. This is a case which I never forget, because this patient, she came presenting to us with bleeding per nipple. And when we looked at the mammogram, we said, yes, she has an asymmetry. She has an asymmetry in the right breast, and it is of concern. When we performed the MRI, there was nothing underlying this asymmetry other than fibroglandular tissue condensation. If you do not magnify, you will miss very important features within the breast. Actually, this patient, she had microcalcifications in the breast. As you see, these are very fine microcalcifications. They are very hard to be seen except if you magnify in the breast. And she performed an MRI, and again, the area following the microcalcifications could be easily missed if as enhancing parenchyma, if you do not look at you do not see the calcifications within the mammography. And this was a case with the DCIS, and it was operated upon. This is another case. This is her mammogram in 2017. She was said to have a subtle asymmetry in the right breast, which was more evident on the CC view. When she came in 2018, again, this asymmetry became a slightly more denser, but according to the ultrasound examination, there was no underlying lesions, and she was asked to come again for another follow-up. This was December 2017, December 2018. She was asked to come after 6 months, and when she came in June, we found that there is subtle developing asymmetry. When we look at the breast, there is definitely an area with parenchymal distortion within the upper outer quadrant of the right breast. We asked for an MRI, and corresponding to the same area, as you see, there are enhancing foci and small nodules within the same area corresponding to the subtle asymmetry. And it was biopsied, and it was a DCIS. In the next lecture, we are going to discuss together the invasive duct carcinoma.